and a hospital pharmacist, and have been engaged with managing medications for patients of all ages. But probably the patients I enjoy most are our older adults, because they have just such great life experiences and so many stories to share. And so I'll share with you a little bit of my stories of working with older adults and falls prevention and medication management, and talk a little about comprehensive medication reviews, if that's something you have not heard about before. So we're going to talk about polypharmacy, which it might be a term you might have heard about or not heard about, particularly in older adults. And when I say older adults, I'm generally speaking from a 65 years and older. However, when we're talking about medication management, I'm talking about anyone who takes any medication, one medication, two medications, over-the-counter medicines, prescription medicines. And so really some of the concepts I talk about today are for all patients, not just for older adults. But we're going to focus on medicines that increase the risk of falls and talk about a rational approach to how do we stop these high-risk medications. I think when I share with a lot of my patients that my job as a pharmacist is to stop them taking their medications, they get surprised. They think a pharmacist is only someone that dispenses medications, starts them on new medications. I'm like, nope. My job is to make sure that your medications are what's best for you, and sometimes stopping those medicines is what's best for you. So we're going to talk about that. Polypharmacy. What is polypharmacy? And this is a controversial topic within pharmacy. I'll just tell you that right now. This slide has 3 different definitions, and it can be lots of different things. But one of the definitions is an excessive number of inappropriate medications. Another one could be use of more medications than clinically indicated, so meaning a medication that you're taking that you don't have an indication for, or just a general definition as 5 or more medications. And when I say medications, I'm not just talking about prescriptions, but I'm also talking about non-prescription, anything you can get over the counter. I'm also talking about dietary supplements, and I'm talking about herbals. And having just done medication reviews with some of our older adults this week because of falls prevention weeks, the number of older adults that bring in dietary supplements and herbals is outstanding, and they do not know why they're taking them. So that alone is the definition of a polypharmacy, that there's not an indication and it's potentially inappropriate. So I'm going to just sort of, for you to think about, those of you who are having watch parties or those of you who are watching by yourself, what outcomes have been linked with polypharmacy? So I have sort of 4 things here on the slide: adverse drug events, cognitive decline, falls, poor adherence. Which of these have been linked to taking multiple medications? So you can sort of jot down your answer of what you think it is. And so I want to talk about some possible consequences of polypharmacy. And you can see on this slide, the answer was all the above. It was a trick question. So hopefully you checked 4 times. So the more medicines you take, the higher risk you are for adverse drug events, the higher risk you are for cognitive impairment, drug interactions, falls. And actually, since this is a falls presentation, the patients who take 4 or more chronic medications are alone at increased risk for falls. So we're going to talk about high-risk medications. So there's high-risk medications that if you're taking one of those medicines, they put you at high risk for falls. But any medicines, if you're on 4 more medications as older adults, there's actually been literature citing that you are at an increased risk of falls. So that is like a huge thing as a pharmacist. When I see an older adult taking 4 or more meds, I'm like, let me do a med review for you. Other consequences are functional decline, increased cost, malnutrition, poor adherence. And you can see here on this slide, not the focus of today's conversation, but you see as the number of medications increase on that bar graph, the prevalence of cognitive impairment also increases. So this is definitely going to be a need about med management and potentially deprescribing. For falls in particular, I mean, I think everyone on this call is aware of this slide and the statistic from the CDC for stopping elderly accidents, deaths, and injuries. But if you haven't looked at the CDC's website for STEADY, there are some fantastic patient education resources on there. There's fantastic medication management resources on there. If you're a pharmacist on the call, there's implementation processes of how do you implement a falls prevention service within a community pharmacy on that Steady website for Steady RX. But this is really a growing burden for our older adults. So everyone should really be engaged and as a team approach, as stated earlier, for helping our older adults manage reduce the risk of falls. So let's get into what some of these fall risk inducing drugs are. And if you look into the literature, sometimes you see them called FRIDs. But these are what we call high risk medications. And these are classes of medications that if you are taking a medication that belongs to this class, only one that puts you at high risk of fall. So now we've tied two mechanisms of how medications can increase an older adult's risk of fall. Just taking 4 chronic medications for any reason, or taking one high falls risk inducing drug. And so this is why it's so prevalent in older adults. So there's the drug classes listed there. But if you go to the next slide, you'll see that these medication classes, here's some example medications. So if you're not as familiar with the medication classes, here's, this is not inclusive. There's a lot more medications you can list under anticonvulsants. There's a lot more medications you can list under antidepressants. And this is why talking to your pharmacist is so important, because they'll be able to distinguish what medications belong to which class and which ones are potentially falls risk inducing drugs that we can talk to our older adults about. One class I do have on here, and I have a star next to, are the NSAIDs, and these are non-steroidal anti-inflammatory drugs. These are the exception that they don't really have a direct linkage to falls. However, I get very concerned when I see my older adults take these, because if they do fall, their increased risk of bleeding is really prevalent. And so that's when I get concerned about those medications. So when I, as a pharmacist, am going through like medication reviews, especially for older adults, I'm thinking about all these things: side effects, drug interactions, falls risk, high risk medications. I'm thinking about which ones cause sedation. I'm thinking about which ones cause urinary incontinence. I'm thinking about all sorts of these things. So I wanted to share with you a typical patient case, and this is like a relatively healthy couple of disease states, 80-year-old woman. She has some diabetes, she has some arthritis, which most older adults have arthritis. She has some hypertension, high blood pressure. Most of them have high blood pressure, and she has some generalized anxiety. Her blood pressure numbers are there. It's a little bit elevated when she's sitting, and it goes down when she's standing. So from my perspective, what that tells me is that when she goes from a sitting to a standing position, she might get a little dizzy. And so I get concerned when there's dizziness, and that's called postural hypotension. So that's one of the questions I ask them. Do they ever feel dizzy when they go from lying down to sitting, or going from sitting to standing? And then I get concerned because dizziness is another contributor to falls. You can see her heart rate there. You can see her weight and her height, and then some labs that I'm not going to talk about. But then on the right are her medications. And so this is a list of medicines. And if you're not that familiar with medicines, it's okay. But I just want to share with you that this is typical. This is typically what I see. And actually, this one's probably not that bad. I've sometimes gotten patients who have 20 medications, and she's only on 3 over-the-counter medicine. And so not too bad. But looking at this list, I'll just give you a moment to think about it. Like, how many of those medicines do you think can increase her falls risk? So we have glipizide and glargine, which are both for her diabetes. We have hydrochlorothiazide, lisinopril, which are definitely for her hypertension or blood pressure. Clonidine, I think, like, again, I'm not sure about that one, but I'm going to guess it could be for her blood pressure. Hydrocodone's probably for pain or arthritis, maybe. Diazepam's probably for her anxiety. Vitamin D, she's probably taking, again, to help with hopefully falls prevention, not really sure. Vitamin C, not really sure. And multivitamin, not really sure. So looking at this list, I like to give trick questions today. Sorry. But all of her prescription medicines actually place her at risk for falls. So this is like, whoa. I look at this, I'm like, okay, I need to talk to this patient first about education, about home safety. I'm sure you've had calls this week about like, what are her homes like? Does she have bath rails? What is she doing at her home to help with falls prevention? So there's a multitude of things. Like, medications are only one risk factor for falls, but this is a patient who every single medication puts her at risk for falls. So she's not just on one medication for high risk, she's on all of these medications, which are high risk. So things to think about as you're going back into your communities and talking to patients and working with your organizations, of how can we increase the knowledge of our connection of polypharmacy to falls within our communities? So how do we get the message out there that 4 or more chronic medications alone increase the risk of falls? Or how do we get the message out there of like all those high medication class, those falls induced risk drugs? How do we let them know that only one of them increases their risks of falls? A lot of people don't make the connection that medications can contribute to falls. So we talk a lot about home safety. We talk a lot about sort of walking and gait and balance, but making sure that we educate about medications as well. And then thinking about yourself, do you have any personal stories related to medications and falls? And the reason I included the conversation about NSAIDs is because I do have personal stories related to medications and falls. As our parents get older, we worry about their risk of falls. As I get older, I worry about my risk of falls also. But there's stories that even when someone's not on a high-risk medication, if they fall and they're taking an NSAID, now that they're bleeding more. And if they hadn't had that fall, even though the NSAID didn't call the medication, they had more bleed. So just this is something that I think many of us have probably been affected personally, and hopefully we can prevent that in the future. So just as you go back to your community, start to share some of those stories and how those medications might reduce their, could potentially increase risks of falls. So I want to get into like, what do we as pharmacists do when you partner with us and the team to help with medication reviews? And there's a lot on this slide. I'm not going to go through all of it, but I just want to share with you the overview of the process of when a pharmacist is involved in team-based practices of medication management. What are we doing? So starting on the left here, we assess the patient. I already mentioned that we're going to look at their medicines. We're going to find out, are they on 4 or more meds? Are they taking any high-risk medications? I might ask about dizziness and the postural hypotension. I might ask about adherence. I'm definitely going to ask about all these things. And I'm going to ask about side effects. I'm going to ask about drug interactions. I'm going to ask about lots of things. Then I'm going to evaluate their medication profile and their therapy to make sure that the drugs are appropriate for them, that they're taking them at the right time, at the right day. The ones that cause sedation, I would recommend that they take them before bed as opposed to first thing in the morning. The ones that might cause them to have to urinate more, I'll make sure that they take those first thing in the morning as opposed to before they go to bed at night, so that they don't have to wake up in the middle of the night. So I'm thinking about quality of life, the timing, the administration of the medicines, the coordination of the medicines when I'm evaluating the medication therapy. If I identify things that the patient maybe is not doing optimally, I will develop a plan and initiate that plan, working with the patient's providers and prescribers and doing a lot of patient education, and then working with the prescribers and the patient using sort of that approach. We will then implement it and then follow up with the patient. So that's just sort of the broad strokes of what we do as pharmacists when we're filling the medications and when we're working in clinics to take care of patients. The things also I'm looking for when I do the medication reviews is I'm looking for these broad categories of medication-related needs. I'm looking to see if every single medication that the patient's taking, do they have an indication? So I mentioned on that other slide, like vitamin C. I have no idea why she was taking that. Like, what's the indication and what has she been told? I hear a lot of times from older adults, oh, I just think it's good for me. And then I'm like, well, let's maybe we don't need that. And I talk about it from like a cost perspective. I talk about it from a safety perspective. I also might find that, that they might need additional medication therapy. Like a lot of times patients who might have had a recent stroke or recent heart attack, there's certain medications that they should be on, and they might take them because they don't feel good or they have a side effect or they just don't think they need it anymore. So I do a lot of patient education around that. I'm also looking for effectiveness, and you can some reasons for effectiveness there. I'm looking for safety. Again, this is more the drug interactions and the adverse medication, adverse drug events. And then I'm looking for convenience too. Can they afford their medicines? Can they take their medicines at the once a day or twice a day? Or are they taking them 4 or 5 times a day? So I'm looking at all these types of things when I do the medication reviews. The other things I do, especially in older adults or for all patients when I'm doing a medication reviews, is I'm looking to deprescribe, take them off of their medicines, which again, I mentioned earlier, sometimes surprises patients. But if the potential harms outweigh the benefits, that's a good time to stop the medications. If it doesn't align with the patient care goals then that's a great time to stop the medicines. I get a lot of questions about values of, do I really need this medicine, especially in older adults. Sometimes we're like, well, the side effects aren't really worth it. And there might be talking to a 95-year-old. And I'm like, at this point, like 95-year-olds are very different. 95-year-old might have like a life expectancy of like 10 more years, and another 95-year-old might have a life expectancy of maybe another year, and sort of getting their feeling of where are they regarding their values and their preferences regarding their medications. And we have those conversations with them. We also talk about current level of function. Yesterday, I had a patient who came in with a cane, and her main thing was she wanted to stop using the cane. And I had to have the conversation with her. Not at this point. She's still taking a lot of medications that can cause dizziness. She was still taking a lot of medications that could, she had postural hypotension. And so she really needed to use that cane. And we had to focus on deprescribing with ultimately a goal. If she doesn't have those side effects anymore, maybe the cane could go away. But then I also need to work with the team members for her to do a gait and balance assessment. And I told her that's not up to me as a pharmacist. I need to work with the team members to make sure that it's appropriate for her to stop using her cane and encourage her to keep on using it. There is lots of great data, and I'll just briefly go over this for deprescribing medications. If you delve into evidence-based literature, there's systematic reviews, there's randomized controlled trials within skilled nursing facilities, as well as community dwelling patients that talk about removing of those medication classes reduces reduction in falls, improves cognitive and psychomotor function. So lots of great reasons for why we want to have patients stop taking their medications. There's also some evidence for deprescribing, which you probably have heard of, the Empower randomized control trial. And if you haven't heard of it, this is a really landmark trial around how community pharmacists can provide education on risks of benzodiazepines and plans for stepwise tapering. And I have a lot of older adult women who are on their benzodiazepines that were started in the 60s. If you remember the marketing, this is a little marketing apparently in the 60s was Mother's Little Helper. And a lot of women got started on the 60s because they had a lot of anxiety around raising their children and just all the things that we have going on as working moms or raising children moms. And so that's how it was started. And it's now, 2020 and 60 years later, and they're still taking it. So they may have started this in their 20s and are now 80, 70, 80 years old, and they're still taking it. And there's a dependency. And if you try to take it away, they do not want their benzodiazepines taken away. So, but it helps us work through how to taper those medicines and how to educate. And you have to slowly taper these medicines, especially for people who've been on it for 20, 30, 40, even 50 or 60 years. And so that with success, there has been discontinuation with some of 27% versus 5% in the control group. And the great news is the number needed to treat is only 4. I see probably 4 older adults a week who are on a benzodiazepine. And this trial really demonstrates that we can do it, but it takes a lot of work and a lot of time to be able to deprescribe those benzodiazepines. There are more resources. This is, I think, when I talk to physicians are so busy doing annual wellness visits, taking care of quality metrics, that they're thinking about starting medicines and they have so many other things to do. Whereas pharmacists, we think medicines first. Like that's our main goal. Like we focus on the medicines and that's what we hone in on. Whereas the physicians are thinking about differential diagnosis, labs, all these other things that they have to be thinking about. And having the pharmacist on the team to focus only on the medications and how it affects the patients is a great help to those physicians. And that's whenever they have sort of a pharmacist that helps them with deprescribing, they're like, please don't go away. And so there's great resources. Deprescribing.org is one, medstopper.com is another. So if they don't have a pharmacist, there are some resources that they can go to as a starting point. And that's the good news for them, that these didn't really exist probably about 10, 15 years ago. So these have only come up in the last 10 years or so. So a lot of the physicians who've been in practice for at least 10 years might not even be aware of these resources. This was the one I already talked about, was the Empower trial. This is specifically for benzodiazepine, and there's great patient education materials. There's great tapering materials that, again, prescribers, pharmacists, nurse practitioners, PAs can all use. And I would encourage everyone, the healthcare team, all can use this and pass this out to their patients. And many times that's what I do. I pass these out to the patients and I say, next time you talk to your doctor, share this with them and see what they can do. So patients is a great opportunity. Some work I've been involved in is we've also developed a deprescribing toolkit for physicians who are very busy. We call it Assess, Then Taper, because many of the medications cannot be stopped immediately. There are certain medicines that you can just stop tomorrow and there'll be no repercussions. But there are other medicines that if you stop tomorrow, your patient will feel awful. I mean, they'll have rebound effects. They will say, why are you doing this to me? They'll lose the trust. So many of the medicines, you have to taper them off slowly. And so this is just a step-by-step process guidance that we have helped with, sort of helping them with the taper, and it's available on the website for people to go look at. So I want to talk about how do we implement these deprescribing practices, because it's so much easier to start a medicine than it is to stop a medicine. And it takes a lot of time. And that's one of the things people are like, well, it sounds easy. Why aren't people doing it? It takes a team approach. I think this is where a PT can help, an OT can help, social workers can help. Everyone on the whole team can really talk about, well, have you thought about stopping some of your medicines? Have you had a conversation with your doctor or your pharmacist about stopping your medicines? And just that simple little one sentence, have you talked to someone about your medicines, really helps, so that when they are with the doctor or when they are with the pharmacist, it gets them in the right mindset. Because many times those patients aren't even in the right mindset to start thinking about removing some medicines. Some great statistics and great but can be improved upon statistics is that when pharmacists do work with prescribers to implement the pharmacist's recommendations following a medication review, the data is sort of very variable. Anywhere from 17% to 86% of the time do the prescribers take our recommendation. There's lots of reasons like why only 17% or why as high as 86%. And a lot of it has to do with relationships. Sometimes those pharmacists might have relationships with prescribers. Sometimes they don't have relationships with prescribers. So figuring out how can we all work better together as a team. One of the studies that I worked on, we were sort of about a third of the time, 32% of the time, that a community pharmacist made a recommendation for falls prevention related to a high-risk medication in North Carolina. About a third of the time, those recommendations were accepted. So there's room for improvement here. I think this is something that we can all do better with medication management and educate our patients, our prescribers, and our pharmacists, and empower us to do more. So just some more questions to ponder as you're in your teams. So now that I've shared some things related to deprescribing or medications, what do you think are some perceived barriers to having patients complete a comprehensive medication review? So just think about what are those perceived barriers, and then how can we overcome those? I did mention briefly, like all of us, encouraging our patients to get a med review. That's huge because they might not even think about that. So that's one that I've thought of. But others that are well documented there's provider barriers and there's patient barriers. For full disclosure, there's also pharmacist barriers, but I don't have the pharmacist barriers on this slide, but there are pharmacist barriers also. But when you think about, again, the provider, it's more the culture that, that they're adding medicines. There's a lot of pressure also to follow disease-specific guidelines because there's quality metrics. Providers have that, pharmacists have that too. Time and complexity. Oh my goodness, that's a pharmacist and a provider one also. Sometimes there's incomplete information. The number of times that I work as a pharmacist, I might not have their complete medication list because they might get something filled mail order. They might get something filled at Walmart. They might get something filled at CVS, and they might get borrow something from their husband or child. And I'm like, oh, and so I don't always have an accurate medication list to be able to do a comprehensive medication review. Similarly, the physicians don't always have a complete information list. I'm always amazed when I'm a patient and I go into my doctor and they ask about my medications. I'm like, no, that one was stopped 2 years ago. No, that one was stopped like 5 years ago. So even like I have the pharmacist and patient hat on, I'm like, oh my goodness, their lists are so inaccurate. And as a pharmacist, I see that my list is inaccurate. So it's really, that's a huge barrier and part of being a detective. There's fragmented care. So as a pharmacist, I don't have the exact same electronic health record for my physician colleagues do. And so sometimes I can't read the same sort of things that they can unless I'm embedded into the same healthcare system. So there's lots of barriers on the provider and pharmacy side. And then from a patient side, there's fear. So I think that's where we all can work together as a team to help overcome that fear, no matter what your background is. There's a desire to maintain control sometimes. There's a dependence, especially some of those medications. There is a dependence on benzodiazepines. There is a dependence on opioids. And so how that there's sort of this dependence that you need. And then sometimes patients are told, I was told I need to take this the rest of my life. And again, that sort of gets that example I gave earlier with the 95-year-old, like, okay, do you need to though? So that's, again, conversations that as we get older, things change. So I want to share with you just, again, I think when pharmacists are embedded into an ambulatory care, internal medicine, or in the same building as providers, it's a lot easier to do medication management. However, a lot of medication management also occurs out in the community where they're not embedded in the same building. And so how can we overcome that barrier and work better with the team-based care? And so I received, again, a grant from CDC a couple of years ago, figuring out how can we utilize the community pharmacist who might not be working side by side with the PAs, nurse practitioners, or physicians to optimize med managements for older adult falls preventions. And I want to share some of the highlights and successes and also some of the lessons learned of where we can keep on going to make this even better. So I'm only going to focus on these 2 aims. We have 4 aims, but I only want to focus on how we implemented the falls prevention program as part of a med review process in North Carolina pharmacies. And then I want to share with you the outcome of the grant, which was we developed a toolkit for implementation that is available for everyone to use now. So I want to share those 2 with you. I'm not going to go through everything. But we had, just quickly, 65 pharmacies. We had a control group. We had an intervention group. We had close to 10,000 patients overall in the study. We developed lots of study tools for the pharmacist and for the patients utilizing the CDC study materials, which helped them with the medication review process. A lot of the materials were available for providers, so they're just listed here. And again, I encourage you to go to the CDC website to look at this. A lot of pharmacists were not aware of these things. I think physicians might be more aware of them. Pharmacists were not, and they have a CE dedicated to pharmacists for older adult falls prevention. And then there are things for patients, which are awesome patient language. So we used a lot of these things for our patients when we were handing them out in the community. So we weren't recreating the wheel. We were already using things that are already available. But what we did do is we tweaked the study process, because the study process was very much from a health system approach or an inpatient health system approach. And that's what's on the left there, the original study protocol of assuming that you have optimal care and team-based care and everyone working in the same building and everyone reading the same electronic health record, but that's not how healthcare works. We're fragmented. And so on the right is what we adopted, assuming more of the fragmented model of care, that you might have a community pharmacist who doesn't have access to electronic health record. You don't have the that physician's office doesn't have a pharmacist embedded in that clinic because they might not be able to afford that pharmacist. And so how can you work smarter, not harder, and have team-based care? So we adopted it a little bit to, the screening was still the same, so that did not change. But the review, again, was more focused on the medications and medications linked to falls. And then the care coordination is probably where the biggest thing changed, because we had to coordinate care, knowing that we weren't all in the same building together. So I'm going to walk through these three sort of steps process. So the screening we focused on was patients older than 65. We focused on taking 4 or more chronic meds and patients taking or patients taking at least 1 high-risk med. And I explained why we focused on those things earlier. This was something that we just documented. We asked them the steady questions about, have they had falls in the last year? Were they worried about falling? Do they feel unsteady? Do they have symptoms of lightheadedness or dizziness? And then the 4+ medicines or taking 1+ high-risk medicines. And one thing we found in this study is that many of the clinics were struggling with their MIPS measures or their HEDIS measures related to falls, that they weren't having enough time to be able to ask older adults about, have they fallen in the last year? And what this did is it took that off the physician's plates. And the pharmacists were able to ask those questions at point of care or point of counseling when we were dispensing the medications. So we would just ask them when they would pick up their medicines, these simple questions. And then we would document it and send this information back to the physician's office so they could document it into their electronic health record. So they got the credit from like a HEDIS measure that they did it, even though it was not part of their workflow, but it was their patient. And we had it documented. We shared that information with them. We had the date on there. And so it was a great collaboration that we could do the medication reviews, we could do the screening, and the physicians could get that taken off their plate, and they didn't get dinged from like a value-based care method. And so thinking about healthcare as a whole and how to take care of our patients. We were really great with the screening. Pharmacists are great at this, and they love to do this because naturally outpatient pharmacists love to talk to people. And so because they love to talk to people, we were able to screen that, like about 4,500 patients in the intervention group. We screening attempts for a little more than 4,000. So we only missed about 400, and we screened close to a little over 3,300. So we had about a 74% total screened. And a lot of them were not documented in the physician's electronic health record. So that's a huge win. Then the next part is we educated them with the patient brochures from STEADY. We assessed for postural hypotension. That's something we can very easily do in a community pharmacy too, with maybe not lying to sitting, but from sitting to standing we can do. And then we did what we do every single day. We did a comprehensive medication review and just focused on the medications. And when we looked at the comprehensive medication review, again, we assessed the med-related needs. And part of that was looking at their current medicines, their prescription, their over-counter herbals, dietary supplements. And we looked to see if there are appropriate indications, what were the patient's beliefs, what are their concerns, what were their past use. And then based on that assessment, we identified any med-related problems or MRPs. And we identified if there are high-risk medications for falls or high-risk medications in general, because it's sort of hard as a pharmacist to separate it. So we do it all, but we're focused in the study for falls, and we look for appropriateness, effectiveness, safety, and adherence. Then if we identify them, we want to develop the plan, a de-prescribing plan, and addressing the medication problems, doing the patient education, and then establishing expected outcomes and time frame for follow-up. And I will say again, when I'm a patient, I will say this is where a lot of clinics fall short. They'll prescribe a new medication, but they won't tell me, well, when should I feel better? Or when should the medication start to work? And what if it is not working within like the 3 days or 7 days that it should be working? What do I do then? And really what you should do is you should be following up. And same sort of thing with de-prescribing. So when you take someone off a medicine, what should you feel? What's the expected outcome? What's the time frame for follow-up? So I think that's another thing that everyone on this call can do, is we can not only educate people, our patients, to ask to get a medication review, but also encourage them to ask questions about the outcomes related to either starting a new medicine or stopping a medicine. And when should you follow up related to starting or stopping a new medicine? And then based on that conversation, when do you following up for evaluation? And then we start the process all over again, because a new med might have been started, a med might have been stopped, and we might have a brand new medication related problem. So every time I'm filling a patient's medicines, I'm going through this process in my head. This is you have the insight to a pharmacist's brain right now. This is how my brain works when I have medications, when I have patients coming into me for medications. These are the things that are going through my head. The other thing we did in this study is we gave tools to pharmacists related to the high-risk medications and how to taper, because again, we get taught mostly how to start medicines in pharmacy school and a little bit about stopping medicines and stopping medicines. So we educated the pharmacists how to do this and gave them some tools and resources for that, which are, again, I can share those out. CDC had concerns with sharing this, but I have no concerns with sharing it, so I can share it. Okay. So in general, I think these are very, very general. Every person or patient you have to personalize the care for their medicines, but I wanted to give this audience some like general guidelines related to deprescribing. Some of the general guidelines are, I prioritize those high-risk medicines. The one that I'm like, oh, you should not be taking that medicine anymore. You're 85 years old. Let's stop that one. So I prioritize those first. And then if I can stop them altogether, great. Sometimes I can't stop them altogether. So sometimes I'm substituting what I call a lesser evil drug for like a more evil drug. They're both bad, but some are more bad than others. And so I sort of have to weigh the risks and benefits of the medications. And sometimes I can't even substitute. Sometimes I have to take the more evil drug, but I'm doing a reduction in dose for the more evil drug. And so that's still a win, is sort of what's going through my head. I do consider input from the patient or caregiver, and if I can taper, I will taper. But in general, usually the newer medicines, newer generations usually have less side effects. So that's usually a good rule of thumb. So asking like, is it a new drug? Is it an old drug? Older drugs usually have the worst side effects. Benzos are evil. And Z drugs are evil. There's a class of antidepressants called tricyclics that no older adult should ever be on. And in our study, actually, that was probably the 33% or 32% of recommendations, probably like 25% of them relate to tricyclics. So physicians are like, why is my patient still taking this medicine? We're like, I don't know. Can we take it off? And they're like, yes, you can. And so there was great news for that one. Also, using a topical medicine, so something you put in your skin or something you put in your nose or something you put in your eye, are usually better than swallowing. So if I am focusing on older adults, if there's a dosage form that I can use a topical instead of a systemic, meaning swallowing or oral, I will always do that for my older adults. Acetaminophen or Tylenol is a great choice for osteoarthritis and for pain. And so trying to start with acetaminophen or Tylenol over the counter first is wonderful. And then using short-acting medications instead of long-acting options are usually just general principles for older adults. All right. So for time's sake, I know this is being recorded. This is just, again, how my brain would work looking at our patient. I see that she's on diabetes. She should not be taking this glipizide. I would stop that one altogether. The Lantus, I would probably continue because I don't want to make too many changes to her diabetes. Osteoarthritis, I do not want her taking this hydrocodone. So I want to either stop that and continue the Tylenol or acetaminophen because that's great for osteoarthritis. Hypertension, again, I try not to make too many changes at once. So these two are probably enough. And I try to start this begin taper because this to me is like, whew, not a good one. And the rest of them, I have to follow up with her. So this is not, when you deprescribe, it's not a one and done. This plan that I presented on this slide here is going to take probably minimum 6 months. It might take 12 to 18 months for all this deprescribing to work. So when people say, well, why don't we deprescribe more often? It's a lot of work. It's not a one visit clinic visit. It is, or one pharmacy visit. It's usually a clinic visit every month or a clinic visit every quarter to assess the medications and keep on following up. This slide just sort of talks about which ones can be stopped without considering a taper versus the ones on the left you cannot stop. You have to taper, and that's the ones that can take 12 to 18 months, or depending how long the patients have been on it. And then our CMR data, so our comprehensive medication review data from our study, we did more than 3,300 patients. Many of them screened positive for a fall. And so based on screening positive for a fall, we then went on to complete the comprehensive medication review and made recommendations based on high-risk medications or based on multiple medications related to deprescribing. So again, we had great engagement with the patients in the community for doing med management. And then the last step that we did, which was new, was the care coordination and follow-up. And this was communicating with prescribers who might not be working side by side with us and who we might not know because they're like, who's this person? I don't work with them regularly. But we would send them either phone calls, faxes. If we did have access to the electronic health record, we'd type in the electronic health record and recommend appropriate medicine changes and actually refer for them to do the gait balance and strength assessment, because that's not within our scope of practice. So we were not wanting to take over their job. That's not what we do, but we were focusing on the medications, which we definitely is within our scope of practice, and notify the patients of any medication changes. So we did get about half of the follow-up communications were received. And like I said, about a third of them, they were accepted. The other, I guess a third of the ones that we follow-up were received were not accepted because they wanted to have a follow-up conversation with them, which was perfectly fine. Then the last thing I want to cover is the toolkit. So these will be available to you. The toolkit is free, and it's co-branded with the CDC. So I just want to make sure that everyone on this call is aware of that free resource and that free tool. There is the medication list. I will say this published medication list is a little bit old now. This one's from 2008. We did update it in 2017. We didn't publish it. So if you want the updated list from 2017, reach out to me directly and I can definitely send that to you. But this one, the one that's on here is readily available if you have access to PubMed, but it's a little older. So then as we finish up today, just another question for you to ponder, how can we highlight the importance of medication management for falls prevention? I think it, like you said, Christine, at the beginning, it really is a team effort. I mean, pharmacists can help with med management and medication deprescribing, but it really is a team perspective of talking to our patients, acting with our patients to making sure that they're aware that medications are one part of the multifactorial approach to falls prevention moving forward. So key takeaways, just as you leave me for the day, or before I open it up for questions, there are tons of medicines that can increase a patient's falls risk. The more that a patient is on 4 or more, the greater the risk. There are tools for those of us who are pharmacists on the call to help identify the medications that pose the greatest risk. Even if you're not a pharmacist, you can do a quick little scan if you're doing a home health visit, or sometimes you can see their medicine cabinets better than I can, and you can sort of compare those lists and alert and work with the pharmacist. There are some great tools for deprescribing that are out there. More and more are being developed, and I think that is great that more and more are being developed. And the study website really has a designated process for screening, which anyone can screen. And then if the risk is elevated, that's where you can refer to either OT, PT, pharmacist, whoever might be the person that needs to help reduce those the risk factors for falls. And I think I realized I forgot to put my last slide with my email address. So I apologize for that. But I will definitely, you can share my email address if people want the screening tools or want any of the resources. I forgot that I had a question slide. I must have deleted it somehow. Question slide with my email on it, and I can put it in the chat as well. So with that, I will stop sharing and I will open it up for questions. I'll put my email in the chat for everyone. And I don't know if there's been any questions that have come up as I've been presenting, but I'm happy to answer questions now or unmute and you can ask them verbally.
I have a question. I didn't put it in the chat, but I've heard that as we become older adults, that metabolism is a huge factor in how we manage the medications that have been prescribed. And it kind of hit me when you were talking about these women that have been on the benzodiazepines and they've gone through menopause and now they're in their older adulthood, and is the dosage of that medication just accumulating in their system, and how do you find that out? Is that through a lab or
Yeah,
I'm just curious how that works.
and I didn't even go into that because that's like, I can see like my students' eyes glazing over as you ask that question, but that is exactly what we teach in pharmacy school, that there's absorption, there's metabolism, there's excretion. Those are all things that medications, when you take when you're 20 or 30 years old, even if it's the same medication, same dose, when you take it when you're 60, 70, or 80 years old, it affects your body differently because our liver works different, our kidney works different, our GI tract works different. And so it's, we're really working, a pharmacist would know that. There are certain labs that we can look at that might be able to help us assess that. So I know as a pharmacist, I need to like look at kidney function because certain medications are excreted with the kidneys. And if their kidneys aren't doing well, I need to adjust the dose of those kidney medications that are excreted via kidneys. Same thing with liver. Those are the two mechanisms that medications can be excreted, liver or kidneys. So I look at liver function if it's something that's excreted via the liver and see, do I need to adjust the dose based on their liver function? So I do look collectively at labs, whether it's excretion for like liver and kidney, and then absorption are sometimes people have difficulty with this acid or they don't have enough acid, and maybe a medication needs acid to be absorbed, or maybe they're on a medication that prevents acid like a proton pump inhibitor like omeprazole or Protonix or something like that. And if they're on those, well then I need to adjust the medication. So these are all things that I saw someone put in the chat, that it's important that seniors need to have a relationship with a pharmacist, just like they have a relationship with their physician. That is the number one message I give to patients. I always ask them, who's your primary care doctor? And they usually answer me if they have one. If they don't, I try to connect them with one. And I say, who's your pharmacist? They don't always answer that question. And I say, you need to know your pharmacist just like you know your physician, because we're going to think about those things because that's how our brain works. Whereas physicians are thinking about lots of other things that their brains work differently. So I encourage all of my patients to find one pharmacy, find one pharmacist that they can really work with very closely, and then they can help with those changes, the way the drugs change throughout your life, and really help you with those sort of things. And sometimes it changes based on a new medicine you get added or a new disease state that gets diagnosed. So you have to think about it from that perspective. Great question.
Dr. Ferreri, thank you so much. This has been really informative, and I'm so excited to just be reminded that UNC has been part of the Steady RX development, which is a really great tool. I have a question as I've experienced it as a patient, but also coming from the Falls Coalition perspective. What is the best way to approach community pharmacists to get this on their radar? Because I know when I've gone with my mom to her pharmacy, they're just so busy, and I always want to talk to them, about this. But what is the best way, if they're not a part of your study, for example, as a coalition, that we could engage with community pharmacists to get this on their radar?
Yeah, fantastic. And gosh, if I had one simple answer for that, this would not be a problem, right? There's not one simple answer.
At least a starting point, I guess.
So I think a couple things to think about. So depending on what clinic or what physician they see, some physicians do have pharmacists embedded in their clinics. And so if they do have pharmacists embedded in their primary care practice, making sure that they not only have a appointment with their physician, but also in that clinic, get an appointment with the pharmacist to do a med review. Now that would be ideal world, that every single clinic has a pharmacist. Unfortunately, that's not true. But if you're engaging more with a community-based pharmacist, I will say a lot of times similar to like the physicians, they have a lot of metrics that they're trying to adhere to. And those that are associated with usually large health systems are the physicians who have much more pressures. And I would say the same thing with pharmacists. Those that are affiliated with large corporations are usually the ones that have a lot more pressure. So I recommend, if you need specialized care from a pharmacist, if you can find a independent pharmacy or a grocery store chain pharmacy, they usually have a little bit more time that they can do patient education and patient counseling, because they don't have the large corporate metrics as much hanging over their head. They still do, but it's not quite as pressure. And those independent pharmacists are really have the mindset of taking care of patients in the community. So there's a great app called cpsn.com, and they have a list of all the independent pharmacies and the patient care services, and some of them do offer fall prevention services. But that is a sort of great way to find in your communities, as you go back, do you have an independent pharmacy that could maybe develop that relationship? And it's a little more challenging, I'll be honest, because I've worked in all settings. I've worked in independent, I've worked in a regional chain, I've worked in a corporate national chain, and the corporate national chain is the most time pressing, whereas the other regional chain and the independent, I had more time, and I also enjoyed that environment a lot more. That's what the pharmacist would be happy, and finding that pharmacist that can find that for you. So that would be my approach, Ellen, is try to identify an independent or grocery store chain that can really help with that, or the clinic. If they have a pharmacist embedded in the clinic, make sure they get a pharmacist appointment in that clinic.
Great, thank you.
Wonderful. Thank you so much. Does anyone else have any questions real quick before we finish up? I was just looking at my local pharmacist as you were talking. So we got a good one in Pittsburgh. I'll plug in for. It's just really nice to be able to go and talk to somebody.
I probably know who that is too.
Well, let me just switch sides real quick. Give me 1 second, everybody. We'll just finish up and give you a couple more resources today. Bear with me for a second. We got all our slides open here. Do you guys see?
We do.
Yes, there we go. Wonderful. Okay, so I just put the link to this. We want to highlight a couple resources for you all. So there's a valuable National Council of Aging's handout that I just put the link to that aligns perfectly with today's webinar. It's a medication review of your doctor and pharmacist, along with tips for success. So we strongly encourage you to look at this when you get a chance with your friends and family. And then, oops, we're out of order here. In addition, some really great resources. If you haven't had a chance to check out the new standingstrongnc.org, this is a really good latest and greatest creation that's out there now for North Carolina. It's got accessible resources and actionable steps to prevent falls. Then, of course, you have our ncfallsprevention.org, which has a wealth of resources as well, partnership opportunities, action plans based on evidence-based strategies, which is always helpful not to have to reinvent the wheel. Healthy Aging NC is a great resource for evidence-based falls prevention and health programming. So if you are not putting your local programming into healthyagingnc.com for everyone across the state to be able to see, and that includes your pharmacists and your medical providers that we're trying to link, please start to do that. Because that's the only way that they're going to be able to see our programs, you know, taking the personal part of this out of it. So please check that out. Obviously, the CDC Steady Initiative, and then the National Council on Aging's Falls Prevention Awareness Week. If you haven't checked that out this week, these are great resources to have. And then, you know, this week, obviously being Falls Prevention Awareness Week, we This is a week we come together with a collective pledge to promote awareness, education, and tangible steps towards prevention. So this is just our week to magnify everyone's commitment to preventing falls and mitigating the repercussions. So we want to thank you all. Our collaborative efforts empower individuals with the essential knowledge and the resources required for a safer, more active lifestyle for all of us in North Carolina. By uniting this mission, we're not only decreasing the likelihood of falls, but also cultivating a culture of mutual support and resilience with our communities, which is important for all aspects of health. If you are part of a watch party today, this is your discussion guide. I didn't see if anybody was having a watch party. Chime in if you're having a watch party this afternoon. I didn't see any in the chat. If you are, do a shout out real quick, or please feel free to let us know how many people are in the room with you right now in the chat before we finish up. But this is a great discussion guide, even if it's just you and whoever else you're going to finish up your lunch with right now. These are some questions for you to have. And then Monday, please, we invite you all for the last session. So this is going to be on the important topic of annual vision and hearing checkup, presented by Dr. Maggie Clifton from ECU Health. And you will use the same link as you have and be back here at noon for that discussion. So hope everyone has a wonderful weekend. Sorry it's going to rain tomorrow, but Sunday looks wonderful. So fall is here. Thank you all very much. Have a great day. Thank you.
Thank you very much.